Good morning, everybody. Um, so, Last week I had a couple of sessions recorded for this week, but after I reviewed them, I realized that the laptop installed mic and camera wasn't exactly what I wanted. So, um, anyway, I'm gonna re-record these, and first thing I'm going to talk about is community paramedicine. Now, community paramedicine is not a new concept now. But a couple of years ago when I built this course, it was. All right. So if you're unfamiliar with it or don't see the benefits of it, let's talk about it. Okay. So ultimately, it is a bridge builder or a gap builder, if you will. Um, we're filling in a gap between those people that have access to emergency care, because everybody does, and that same pool of the population that doesn't have access to ongoing medical care. Okay, they don't have a PCP. So the patient demo that we're talking about today, at least in this section, is the folks that call 911 because they have no primary care. Okay, can't afford it, don't have it, and ordinarily would fall in the cracks of the healthcare system. Okay, but the community paramedic can also put on other hats and do other things for the community. Okay, so um, it's weird to be talking about something in the abstract when lots of places are utilizing community paramedicine. Okay, so let's talk about what they do in case we're unfamiliar with it. It's not a traditional 911 you call, we haul response model. That's not it. This is more akin to home health nursing. Okay, now um, historically, medics and nurses have not gotten along, haven't seen eye to eye, and I think that's kind of ridiculous. We're all members of the healthcare team, so to speak. And in this case, in the community paramedic case, that couldn't be more true. Okay, so what? Think about your skill set. You go in, you make patient contact, you build rapport, you get people to share details, and while you're in there, you're assessing their life. You're assessing your patient, yes, but you're assessing what's around you. We're very good at that. Okay. So instead of an emergent sort of, okay, I've got to solve this medical emergency, I've got to get this patient to definitive care, now we're using those same skills, okay, for assessment, for rapport building, and what have you, to make that contact with the patient, with their family, so that we can maintain this patient at home. Okay, so they don't have to go to the hospital. We all hear and say about people calling 911. They don't have to. They don't need to go to the hospital. They just need this or that. Okay, well, community paramedics see that, recognize that need, and arrange for this or that for them. Now, um, we're basically slightly below a PA, equivalent to a nurse. We're basically the same thing we always have been. The eyes, ears, and hands of a physician on scene, because they've stopped doing house calls long ago. Okay, we're able to figure out what's going on. We're able to assess our patient and that situation. We're able to put ourselves in that place, make a connection. We are the utility. We are the Swiss Army knife of healthcare. Okay, and I know that's kind of a trite statement, but we are. We have a big skill set, and we fit, and can. We are very malleable. We can mold ourselves into what the community needs, and that is an excellent skill set. That's an excellent attribute to have, and I think going forward, it's going to make us vital. Okay, even more so. Okay, just in a non-traditional sort of way. Now, with the introduction of this, okay, there are established textbooks and certification processes to become a community medic. Now, how your community uses them is going to vary depending on location. Okay, but When you become this community paramedic, what you're likely to see is not a, a rapid assessment of the patient in the interest of getting them to a thing, a place, a certain hospital. It's more of making sure that that call doesn't need to be made. Okay, so how do you treat a heart attack? You know, 100% appropriately, you prevent it. Okay, so going out and doing things like on the screen you see home safety assessment. We look at people's living rooms and think that old lady's going to fall over that cord, that rug is loose, we got to wash that. Scene safe BSI. We've heard it ever since you got an EMS. Okay, so now we just apply that and play the what if game. What if this person, all right, low light environment, they're going to trip, they're going to fall. They're kind of a hoarder, we need to get this thing cleaned up. They need this or that. That's what a community medic does. Okay, they make a difference by learning their patient, going into their environment, and then, God forbid, let me say the E word, educate. Okay, they educate their patients on what they have. Okay, disease conditions, etc. They teach them about their medicines. They teach them about their own bodies. Okay, they do wellness checks to prevent that 911 call. If you don't want an overburdened 911 system, well, let's educate people. Some people are intelligent, some people are far from it. But as a whole, what I've noticed over decades in and around the EMS is people are blissfully ignorant when it comes to how their body works. And only when there's a problem will they start trying to figure it out. Okay. And if you think about the geriatric population, those, in a couple of generations, it won't be like that. Okay. I'm sure there are some Google doctors, of them. They've already Googled their problem. They've got a diagnosis when they're waiting on the front porch for you. Yeah, that's coming. But right now, the geriatric population might not be that in tune with, seeking out the knowledge of, their symptom pattern. All right. So we're going to fill that niche for a while. Okay. Community paramedicine programs based on expanded role for paramedic and, NHTSA, gotta love them, national standard curriculum. Now, like I said before, each location is going to vary what they offer and cater to the needs of the community in which you live. Now, with these community paramedicine programs, looking at what that community needs, we're also still looking at primarily an EMS agency offering a service, okay, providing a service in conjunction with the hospital, primary care physician, medical control, all multifactorial and multi-dimensional team model. That's what we're looking at, okay? But it all starts with figuring out what does the community need, okay? Now, if you want to look at a historical perspective of what community medicine is, it goes back to something called the Red River Project. And I was talking about this when I first became an instructor in 2006, okay, because I gave paramedics credit for knowing more than just the gas pedals on the right, the brake pedals next to it, and this is how you turn on the lights and we're going to drive fast. Okay, we're capable of more. So I am and have always been a big proponent for increasing skill set. I'm not the only one, obviously. So in the interest of serving the community better, the Red River Project back in 2005 started looking at rural, outlying, don't have much in the way of offering medical care, etc. What can we do about that for our citizens? Okay. Now, the big push in the United States came from primarily upper Midwest, Montana, Idaho, where you got lots of land, a few people, and not a whole lot of services. They're compacted. And when you've got places like Raleigh, Durham, okay, Chapel Hill, you've got a couple of level 1 trauma centers, and you've got progressive EMS agencies. You initially, community paramedicine wasn't about that. It was filling in the gaps where you didn't have a primary care physician in this entire area, this entire community. So EMS being what it is an essential service. Well, if you put your minds together, a doctor who's out there and can't be everywhere all the time, how about if I expand the scope of this paramedic so that they can be my eyes and ears, and then I don't have to be, okay? I can provide the same kind of service. Basically, I'm just outsourcing it, okay? Having that physician extension possibility. In 2015, more than 33 states had community paramedicine and mobile health programs. I'd be shocked. This is, just groundwork from an old textbook, but I'd be shocked if all 50 states did not have that at this point in time. I would be shocked and amazed, because with the healthcare industry being what it is, and with EMS being what it is, we are still filling in those gaps, and those gaps are becoming wider and wider. So some things that we're seeing now. Okay, mobile integrated healthcare provides services utilizing allied health professionals, including community paramedics. Minnesota was the first state to establish licensing for this. Now, with that, if you're an EMS, all of the card classes and all of the, alphabet soup that you can get behind your name, your name tag. Your rocker arm can only handle so many letters, but what I want you to think about is going through an established program, okay, gives it more credibility, just like nurses go through CEN, certified emergency nurse, or the various alphabet soup courses that they have. Critical care and community paramedic, that is a big leap in skill set. Okay, now for that you got to have oversight. Everybody, we run the risk, if we don't have a standardized way to present education, we run the risk of Billy's version of what critical care paramedic is, or Billy's version of community paramedic, where, okay, Billy's the instructor at that college. Yeah, he knows. Okay, well, let's trust Billy. And then I say, you've passed this, and go on. And then you go out and you try to do the job, but I haven't prepared you. I've prepared you for what's locally an issue, locally how we do things, and then you move. Okay, so just like the paramedic curriculum, standardized curriculum has to be a thing. Okay, now all of that to say this, even though they've been building on this idea, and accreditation started in the early 2000s, we're still feeling our way when it comes to community paramedicine. Okay, and that's because even though it's a standardized sort of curriculum, it can't be a standardized thing, because every community has different needs. Okay, and every community has different capabilities. If you'll notice that third bullet point, funding models. Okay, not everybody can afford the same sort of services. Okay, but if we're going to fill these needs, it's going to be something that has to play a role, and that goes back above our pay grade as paramedics. With this, we cater to what the community needs. Okay, now I'm going to fast forward just a little bit and not bore you with the requirements of community paramedic. Um, you know that if you're going to, there's a process. Okay, you're going to have to go through an established curriculum. You're going to have to ultimately take a test because everybody tests everybody, and then you've got to work within that, the training of what the community paramedic is going to be in that community. Okay, and then you have to figure out how they do things, because not everybody does the same thing the same way. Community paramedics follow the scope of practice defined by NHTSA. They work under the direction of a medical director and the patient's primary care physician. So how do patients get into community paramedic? How do we get there? Okay, well, it's physician talking to physician upon discharge perhaps, or after office visits, seeing that that person is not taking care of themselves, where those arrangements are made. Okay, a primary care physician can act or may act as a program medical director. Okay, it can be a a doctor that has oversight of a decent patient size, or um, a hospitalist, or an internal medicine doc, um, where they have patients that have an established need. Okay. Now, with that, you got to have patients to go, not patients, but providers to go out and fill that need. Okay, and that's where we step up to the plate. Now, what do we do? Well, we go out, we do home needs assessment, we provide that safe environment, looking at are they taking care of their daily needs, our activities of daily life, okay, their ADLs. Do they know about medications? Is there a safe way for their medications to be administered to them? Are doing pill counts? We're doing a lot of different things, but basically we are the eyes, ears, and hands of that primary care physician. Now, it's great to have a discharge plan, okay? And that discharge plan says you need to drop weight, or you need, in this case on the screen, you need to reduce cholesterol by 10 points. That's an awesome plan to have. But if you don't inform during discharge that person on how to do that, they're going to go back to the same environment, eating the same foods, and nothing's going to change. Okay, so since we are great at rapport building, we go out and explain. Okay, you can't have bacon as a food staple. Sorry, your barbecue intake has to be cut down. And then another one of our roles is to be basically an outreach individual. We're going to be a member of the team, and we're going to arrange for, recommend, however you want to put it, other ancillary services. Okay, occupational therapy in some cases, physical therapy, speech therapy, psychological counseling. We're going to be almost like a case manager, sort of. Okay, we're not technically a case manager, but we're going to be kind of like a case manager in the fact that we are looking as that patient advocate for what is best for them. What is it that they need? We're great at doing our job most of the time, but we can't provide everything. So if we know who can, that's when we fall into this team concept. Okay, now you've got this expanded scope of practice. Okay, you've got this expanded responsibility and skill set, but then you kind of have to mesh with the existing team. Okay, and that existing team, that's going to be some of the people that in the past paramedics have loved to hate. Okay, home health care, nursing, ancillary services like occupational therapy and physical therapy and that sort of thing. With us being part of the team, we have to be able, we're great at communicating with patients, and sometimes we let animosity prevent us from having good professional relationships with other team members, and we've got to We've got to accept our role, so to speak, in this team and know that that's not applicable. Okay, to be a patient advocate, then we have to do our team member stuff. We've got to be a good teammate, right? So the team is like a medical director, physician, EMS system, nurses, social workers, case managers, all in the interest of the patient, all trying to make sure that this patient doesn't fall through the cracks of the healthcare system. Your medical director serves as liaison, supervisor, resource evaluator, and conduit. Now, what does that truly mean? We're used to medical directors by fiat dictating what we can do and can't do on ambulance calls. Well, in this case, your medical director is going to, for this role, is going to be looking over what you're doing and looking over patient outcomes and determining, are you basically effective in that role? Is this program being effective in that role? Okay, so they're also going to be the resource that you call and say, this is, I've done all of the testing, or I've done all of the evaluation, and these are what I think. Okay, and in some cases it may be a phone call. In some cases it may take written reports that are sent up the chain, and everybody gets their input, and then a collaborative plan is made. Okay, and then we carry out the plan. Cool. And I say we, it's not just the community paramedic. Okay, it's not just community paramedic talking to a doc. It's not the 911 model. Hey doc, I've got this. This is what I'm thinking. I'd like to go ahead and do this. Okay, well, you're bringing them into that physician potentially, or taking them to an ER. In the community paramedic, you're likely not. Okay, so having a bunch of different eyes on that patient, having a bunch of different hands in the works. Sometimes that team model is great. Having more brains on a problem, that's how stuff gets done. Now, their physician, okay, or the physician, plays a vital role in terms of how community paramedic monitor and manage a patient. Must have commitment and belief in the program. You have to have buy-in from the primary care providers in that area. Okay, they've got to recommend patients to it. They've got to then hand off to the medical director of the community paramedic program, so to speak. This is Ms. Johnson. She's got problems with diabetes, and all of these other health-related issues, and we're trying to get her better controlled on her insulin, and yada yada yada. Okay, cool. They work up some objectives, and now it's time to send out the team to evaluate and to help. Okay, if you don't have primary care providers that believe in the possibility of this, then you won't have patient referrals to it. So you can provide a service that nobody sends their patients to, and you're not providing service to anyone. EMS system must have a link to the existing 911 system. Okay, so not all, but most community paramedic programs are going to be run in conjunction with the local 911 system. Now, when I say not all, I posted a couple of links about North State and what UNC Healthcare is doing, that integrated approach. Okay, now the reason I say I don't consider North State a 911, well, they're not. Okay, but they are a contracted transport company, and that transport company has to have license in that community. So it's not like the primary 911 system doesn't know what North State is doing. They're on the franchise agreement in that county. So, just saying. Most of the time, though, it's the 911 agency itself that is now going to, okay, we're doing this now. Cool. But I digress. Okay, community paramedic maintains continuity of care, can discover emergent condition, activate EMS, and transport if necessary, can provide a full patient history. You get to know these people, and you get to know all about these people, and all about how over the past 6 months they've had a decline, or this has changed in the past 3 weeks. In 911 response, we play a guessing game sometimes as to how long has this been going on. Community paramedics, they're going to know because they have an established relationship, and they can give you that backstory. The other members of the healthcare team, nurses, okay, they play a critical role in home and primary setting. They can come in and do sometimes what the community medic cannot do, okay, as far as, you know, giving medications and arranging for things that a 911 medic would never be able to pull the trigger on. Okay, now with that, hand in glove, you got to work as a team. Okay, and again, historically, sometimes we've been better at that than others. Now, there are a couple of instances in 911 response when a paramedic has to contact through their chain of command social workers or some other service, okay? And most of the time we know what that is: child abuse, elder abuse, and the mandatory reports, okay? But now social worker connects patients to community paramedicine program and primary care physicians. Some of those folks that 911 has clued these social workers into the fact that they need help, well, we're going to get a bounce back referral that, yeah, you're right, they do need help, and they need this kind of help. They need a healthcare team. They need this community paramedic and this mobile integrated healthcare to go out and take care of them. Otherwise, they're going to become your frequent flyer. Okay. And you help with a lot of different things. Case manager coordinates appropriate care, refers patients to community paramedicine program, acts as a conduit for information to their PCP, and basically you become a facilitator as a case manager. You facilitate what the patient needs and arranging different ancillary services, x-rays, CTs, lab work, etc., etc. And then that person becomes the hub of information to then disseminate that information out to the people that are going out and dealing with them, the community medic, or who wanted that information to begin with, the primary care physician. So in order for this to work, okay, you got to figure out where the gaps are in the community. Okay, first they have to be identified, and then you've got to build bridges. You've got to make sure that everyone has buy-in. Okay, so when you see that foster relationships with community organizations, that's hospital, that's money, that's services, that's okay. This is what we want to do, and this is how we need to get it done, and we need your help to get it done. Okay, we're all one big healthcare team after all. And then if you can get that buy-in and you can then get things done. Okay, EMS by itself sometimes doesn't have the loudest voice. Okay, so that is just some basic, very basic background on community paramedicine and how things like that got started. Okay, now I'm going to change roles. I'm going to stop sharing that window for a second. You're going to see my ugly face, but I'm going to switch roles and go into critical care. Okay, now if you thought that critical care is your dream job, for instance, okay, critical care is a different animal. Critical care is it's a lot of information. It's a lot of responsibility, and you should be seeing that. Okay, so again, I'm just doing, for right now, I'm just touching the surface of this sort of thing. We'll get into more information on critical care and community paramedic when it comes to assessment and other factors later on in the course. Okay, but right now, okay, everybody knows what critical care is. That's those great big trucks. That's those helicopters. Those are airplanes in some cases, transporting sick as snot patients. Or yeah, well, if that's your understanding of critical care, I doubt it is at this point, but let's see if we can dig into it a little bit more. Okay, the critical care field itself is a subspecialty, and it's growing. Why is it growing? Because of the need. Okay, lots of places, hospital-based services typically, lots of places need the ability to transport into and out of that facility, depending on what the patient needs. Okay, and municipal EMS agencies can only do some. Okay, so again, we're filling a niche. We are bridging a gap. Primarily, when you think of critical care, you think of interfacility transports, and that's going from small hospital to big hospital. Okay, and yeah, that's probably true in most occasions, but when you're talking about critical care, we all provide critical care. Okay, but if you look at OEMS guidelines, okay, if you looked at the 13P, that's the rules that govern an EMS agency and have all EMS agencies. Anybody that does pre-hospital transportation and treatment of anybody sick or injured, the 13P is the law. Okay, it tells me how we've got to run an EMS program at a college. It tells you how you've got to run 911 response, and it also dictates SCT, or specialty care transport. Now, what is considered specialty care transport? Anything that goes beyond what normal 911 is going to do, but can be handled by a paramedic. Okay, so it might be a medication, it might be a piece of equipment. Okay, all of us were taught a little bit about ventilators in school, and I teach people about ventilators. But as far as how to use all of the ins and outs of it, most EMS agencies, 911 responders, don't have the kind of transport ventilators that specialty care has. Okay, most 911 providers are not going to be hanging the drips or as many drips as a specialty care transport is going to. We don't even have the, it's obvious we don't have the crew configuration that SCT does, because there aren't too many nurses jumping on an ambulance. Okay, not a 911 ambulance. So basically what we're talking about is the sickest of the sick. And 911 medics talk about that patient didn't need that. They walked past 3 functioning cars to get in the back of my ambulance, blah, blah, blah. Okay, well, 99% of the time when you're talking about SCT, you're talking about the sickest of the sick. Okay, and there is rarely an instance where you wouldn't be worrying about the patient that is in front of you. Okay, now when we talk about crew configurations, okay, on a 911 truck, it's an EMT or a medic, a dual medic, whatever, and then you've got, that's about it. There's not a whole lot of variation in it. But in critical care or SCT, it all depends, okay, on the agency that you work for. Duke, depending on what the team designation is, you've got an EMT driving, you've got a paramedic, you've got a nurse, okay? But you could also have an EMT driving, you could have a respiratory therapist and a nurse, okay? That's your PEDS team. If you're, you know, if you're dual medic, you've got that in flight crews throughout the state. It just depends on where you work, okay? But then again, you can see that third bullet point, whatever the patient needs, you might see some new folks jump on that truck, okay? Neonatologist, intensivist, perfusionist, you know, what if you're going to a sick as snot patient and carrying them to Chapel Hill for, you know, they're on ECMO, they've got a balloon pump, they've got, you know, they're on bypass. The laundry list of things that could be wrong with them is so wide and varied, there's no way to even mention all of them. And that's just talking about adults, not to mention all the NICU, the sick PDs, the kids that those pediatric teams go out and get that are, you know, less than half a kilo at body weight, 20 something weeks. And now that's your skill set. You're going to go transport that from BFE hospital to that state-of-the-art PICU and NICU. Now, when it comes down to it, lots of people think about critical care and flight medicine. Okay, I'm going to talk a little bit about flight medicine at the end of this and some specialty concerns that we have to be cognizant of if you want to fly. But here you see atypical offloading, and now, okay, blades aren't rolling. You got them taking the kid in there. Stage photo, awesome. But how do you become that CCTP? Okay, critical care transport provider. Educational qualifications able to provide this care at the same or greater level than a non-CCT counterparts. In other words, critical care medics do know more than you, only about certain things. Okay, now, would I want a CCT paramedic taking care of me on the street? Not if they didn't have 911 experience. And here's something for you to think of. Most critical care medics, most critical care programs require that 911 history. Okay, that's some of the things that we make up that nurses, as good as they are, won't have. Okay, full disclosure, I'm married to a flight nurse. Okay, I know a lot of people that work for Duke. I know people that work for Chapel Hill. I, at one time long ago, worked for Air Care, okay, as a driver, and worked around some great people. But it's a different animal, okay? They know more about drips and ventilators and conditions that they transport all the time. The nurses and medics that do that sort of thing, my hat is off to them. But again, if they don't or didn't have that 911 background as a paramedic, I would rather see a 911 medic hovering above me, following, you know, some sort of slip and fall or some sort of accident than a critical care medic. Now, where do they supersede what we know? Okay, surgical airways. Well, it's cutting a throat and putting in some airway. Everybody can do that, but they do some of the airways that you may or may not have ever heard of, like a milker, for instance. Okay, it's basically a retrograde intubation. If you don't know what that is, that's because you're dipped in modern EMS. But retrograde intubations, they're You introduce a transducer that goes through the skin into the airway. You go backwards, and then you feed it over that, and then you're in the airway, and that's how you get definitive airway. And it's quite a lengthy process, but that's just one illustration. Okay, chest tubes, we know how to maintain them in 911. We don't deal with them that often, but we know what they're for. Okay, blood product administration. This used to be the specialty care genre only. That's no longer the case. There are some 911 agencies throughout the state that have begun to hang blood. Pericardiocentesis, yeah, you're not going to find that in the state of North Carolina. Okay, the National Registry used to talk about pericardiocentesis, and critical care used to. That's not really a thing that we are likely to do, ever. Anyway, escharotomies, again, I don't know about cutting pressurized skin, burn skin. I don't really see a whole lot of that, or have heard of a whole lot of that. Transporting it post-procedure, yeah. ICP monitoring a bolt or somebody's ICP, yeah, that happens a lot. Balloon pumps, yeah, that happens a lot in critical care. Central line, obviously all day, every day. Invasive arterial and cardiac pressure monitoring, yep, okay. And lab testing and diagnostic imaging. Now, if you think about it, the basic paramedic curriculum doesn't deal with a lot of lab values. I mean, I talk about them, but we don't deal with a lot of them because we don't have the lab. Okay, if you're doing an inter-facility, they have the lab. They have the lab data. So knowing what that is and knowing what that means holistically to the patient's condition, that's probably a good thing to know. Okay, diagnostic imaging, you know, what their CT shows. We never have a CT on the 911 side, so it's not in our realm. Being able to troubleshoot a ventilator. Use of portable ultrasound. Again, portable ultrasound in the past may have been only in the purview of specialty care, but now throughout the U.S., if you can afford it, EMS agencies are using ultrasound to varying degrees and for various things. Okay, you can use it from finding intra-abdominal bleeds, determining if cardiac arrest is present, or do you have any pumping function of the heart in asystole, you know, or I hear a silent chest. What's fluid, what's air? You know, you can actually see intracranial hemorrhaging with ultrasound. So you can do all of that, and you can find a vein. I mean, it's got a lot of uses. And if they ever make it paramedic proof and tough enough and cheap enough, it's likely to go into wider usage in the 911 side. And that's why later on in the course we'll be talking about ultrasound, we'll be talking about some other things. Okay, a variety of catheters, tubes, and drains. We don't typically deal with that. Okay, so for critical care programs, you got a bunch of Con Ed that you have to do. Okay, now depending on what you are certified as, it kind of dictates, just like state versus national registry. Everybody's got Con Ed to do, and if you've got CCP or FPC, you have to have yet another certification master to placate or to appease to get that certification re-credentialed. Okay, not to mention the cost of the testing for FPC or critical care paramedic. It's rather pricey. Okay, so if you know, national registry is a pain in the butt to get, it's a pain in the butt to lose. State, you know, you could lose your livelihood, but CCT or FPC, I think the last time I looked at taking it, it was about $350 just to sit for the test. Okay, now that's a commitment, and if you don't keep up your Con Ed, just like every other oversight agency, they'll take it from you, and then you'll have to pay to get it back. Okay, so um, their Con Ed is going to exceed in the scope of what the street medic needs. Okay, depending on where you work as to what the team configuration and team members may be. And sometimes it may just be specific to a call, okay, as to whether you have a fellow jump on the ambulance or fly with you. Not every call will you have a perfusionist. You know, it's just what is needed for that particular call, okay? So when we talk about patient acuity, distance between sending and receiving facilities, ability of transport service to respond, weather conditions, regional topography, what's the mode of transport? What does the patient need? How sick are they? How quick do they need to be here? And what is available? Okay. Most of the time, you'll see the big, sometimes they're referred to as war wagons, but those oversized critical care trucks. Okay. Now, they're an ambulance, they just have more toys. Okay? They've got a lot more toys, potentially. Um, they have a checklist just like a normal ambulance has a checklist. Okay? And if you can get by with doing that, that's, you know, the flight medic. The only difference between a flight medic and a medic in the critical care truck is if the truck breaks down, the critical care medic is safely on the side of the road. Okay. How it's utilized can be about the severity of the patient condition, weather conditions. You know, a lot of those factors and variables come into play when a critical care provider is contacted about a patient transport. If you're thinking rotor wing is something you'd like to do, use to transport patients in rural settings, can travel up to 150 miles. Tell you what, folks, most of the time, well, not most of the time, you are also going to see them exceed that 150-mile range, depending on what they're doing and why they're doing it. Okay. I've known Duke to fly out to the coast from Durham, their Durham Henderson base. That's quite a ways away. I'm talking Dare County, etc. I've heard them go to the mountains and fly out there, say Asheville. That's again probably over 150 miles. So there are no hard, fast rules. If it's a couple of 100 miles, then you're likely to have that rotor aircraft arrange for fuel stop-offs going and potentially coming back versus trying to do a fixed wing, which is the airplane or a jet. Okay. You see some various platforms here with some of the, you know, the helicopters that are out there. When you think of medical helicopter, here are some other different models. Okay, you got a BK-117, you got a Bell, you got a Sikorsky, you've got an AW-109, and down here you got a Dolphin. Now, most of the flight services in North Carolina that I know of, they're using the Eurocopter, the EC-135 or 145 most likely. And when you come in contact with that, you'll note one thing. There's not very much space. Okay, the bigger the Dolphins, you know, some of those the really big looking helicopters, they've got a bit more space, but it's kind of tight in there. Okay, when you talk about fixed wing, okay, now we're talking about jets. Okay, and They can fly around the country. They can fly to other countries. They fly to the Caribbean to pick up patients a lot. Okay, so depending on what the patient's need is, I've known, again, my wife works with Life Flight, so just some of their stuff. Flying to Maine, flying to the West Coast, flying to the Rockies, flying down to Florida, all to get patients to bring them back to Duke. Okay, it happens a lot. Fun fact, Duke doesn't have a jet. Okay, most places, even hospital-based services, most places don't have a jet for this purpose. So what you're likely to find is it's a rental. Okay, and they essentially rent it from another service that does have that flight capability. And what do you think that does to the cost of said flight? Anywho, um, when we come down to it, all of that, let's talk about the process. Okay, so you've got call takers, you've got dispatch center just like you do for 911, and you call for services. The first person you're going to hear from is a dispatch, and then you're going to probably be referred to an area that is more clinical rather than just information-based gathering, and they're going to decide, what kind of setup we need. Okay, now this is all after, or this is the process of that smaller hospital most likely calling that larger hospital and seeing if they can transfer the patient for surgical services or specialty care. Okay, so you can't forget the legalities of it. Okay, you can't just, okay, this patient's sick, let's get him out of our hospital, just take him up to UNC. Okay, and not have a doctor that's accepting that patient. Okay, that would be an MTELA violation. So there has to be a lot of communication between physician and hospital, to other physician and other hospital, and then once all of this is established, or while it's being established, we're trying to figure out what our crew configuration is going to be. Okay, what does the patient need? And then what resources do we need to take? Okay, now most of the time they've got standard bags and packs that they're going to take, but it's not like they, if they don't carry an isolette on everything. Okay, but if they have a sick neo, they're going to carry an isolette, that pediatric team. Okay, so you've got all of these different things that they're going to have to potentially take. Okay, on every call, or depending on what the situation is. And then let's think about the advantages and disadvantages. Hopefully you can see this. And if you think about the mobile versus rotor wing versus fixed wing, all of them have advantages, okay, but all of them have disadvantages too. Kind of a no-brainer what a ground ambulance advantage and disadvantage breakdown is. We know that, we work in them all the time. Rotor wing, okay, for the advantages: speed, 100 to 180 miles an hour, okay, typically in a straight line, but there might be areas that they have to fly around depending on flight patterns, air traffic control. They're subject to no-fly zones, just like other things are, like over military installations, etc. They also have to worry about towers and impedance and that sort of thing. Okay, so they can go really fast, and that's cool. But then again, if you look at the disadvantages, weather, interior space, I mean, they basically have to take a tape measure and see what the girth of the patient is to see if they can even fit in the clamshell doors on the back of that aircraft. Okay, and if that patient is too calorically gifted, too obese, too round, okay, to go in the back doors, the patient can't be transported. These ambulances, they're what, 100,500, okay, say 150,000 for a critical care truck. For an EC-145, if you buy it, you're probably looking at somewhere between 8 and 10 million. Okay, you got to have all of the specialty stuff as far as where you're going to land it. You got to have your communications. As much as we think ambulances are bumpy, and they are, aircraft, even rotor wing, they are hard on the body. Okay, we'll talk about that in a little bit too. Expensive for the patient, requires special housing. Okay, you can't leave $8 million helicopter out in a storm. You got to have a heli wagon that you have the ability to bring that helicopter into a hangar, and when the storm's over, you might be able to put it back out. The weather conditions being what they are, you might not. Okay. Limited space and weight limitation. The pilot or the PIC, pilot in charge, they have to consider weight of the crew. Yes, you don't like talking about your weight, too bad. You're going to be weighed annually, if not every 6 months, to make sure that you're not over weight restriction. You got to know the weight of the crew, the weight of the pilot himself or herself. They got to know the weight of the fuel that's going in the helicopter and the weight of the patient. They've got to factor all that stuff in to know if they've got enough fuel without having too much fuel. And yeah, okay, all of that calculus before we can really even go get. Fixed wing aircraft, hey, great. Jets are pretty fast. No weight limitation, go great distances. However, if you look at the disadvantages, adverse altitude considerations, effects on patient and crew, need for FAA communications, expensive for the patient, expensive to operate and maintain, can only serve a small portion of the community, require special housing and special landing requirements, i.e. An airport? Yeah, okay. So, at least with rotor wing, you only needed a, helipad. Now, all that to say, get you acquainted with all of the different considerations of their good points and bad points. So some agencies have auto launches. Let's put it in the realm of rotor wing, okay, helicopter. These aircraft can be auto launched anytime a 911 call goes out for an MI or a CVA or severe trauma. And then again, sometimes, agencies get on scene and decide, I need an aircraft, okay? But our extrication is going to be X amount of minutes. Okay, well, we got time to call for a helicopter. Anyway, when you've got time-sensitive, high acuity patients, that's the great time for critical care. Now, just because it's sunny over you doesn't mean it's sunny between that flight servicing you. Okay, so lots of different things go into can that agency respond to your emergency. Now, they look at different things. They have different tools and toys. They've got different, skill sets. They've got different treatment parameters. But they still have the same kind of oversight. They still will call back to their medical control and consult. Okay, or it might be a fellow, that the patient's being transported and going into that service. Well, they're likely to talk to an attending or a fellow that, hey, what do you want me to do before we lift? What happens if this goes on? And, this is what I'm thinking. This is what they're looking like. Basically making sure that that doctor knows what that crew got and found once they made contact with the patient. They've done their assessment and Okay, before we lift, before things get sporty, um, let's analyze this. Two types of medical oversight. Now, state and national standards, you know, OEMS in the state of North Carolina is going to tell you what you can do, okay? But depending on the flight service that you, or the critical care service that you work for and with, you're going to see them get really, really tight. Get a pucker factor when it comes to CAMES accreditation, okay? Um, I'll talk about that a little bit as well. But everybody's got multiple masters when it comes to EMS or critical care. Those oversight boards are no joke, and people take that stuff extremely seriously, as they should. If you've ever seen a hospital tighten up because JACO was in-house and doing their inspection and overviews and that sort of thing, CAMES accreditation does the same thing for most critical care agencies. Okay. Now, this section of it talks about the different stress and well-being. Well, that's not much different from, what our well-being approach should be and what our stress management should be as 911 controllers. The only difference is sometimes, we've got calls that are funny, for lack of a better term. Sometimes it's silly stuff. And critical care, again, most of the time they're going out for the really sick, the sickest of the sick. Okay, so when it comes down to it, their stress, the cumulative stress, can sometimes catch up to them. Okay, now I'm not going to pretend that I know what being a critical care paramedic is. Okay, because I haven't had to do that job. I did it part-time many years ago when I was affiliated with UNC. And at that time, you know, uh, I was driving. So when it comes down to looking at the critical care stress level, I can tell you what I've observed having friends that work as critical care medics and nurses. Uh, they do get stressed out, but just like 911, they get stressed out by things that aren't necessarily patient related as well. Okay, so a lot of it is the people they work with and the agency they work for, more so than the patients that they deal with. Now, here's something for you to think of: CISD and psychological first aid. CISD, approach favored since the 80s, largely replaced by principles of psychological first aid, meaning take care of your own. Okay, talking about and trying to facilitate resilience in the workplace by your coworkers. That has borne out more so than the more formalized, kind of delayed CISD. Okay, now in critical care, because you're talking about a different sort of patient and sometimes a different vehicle, you're talking about wearing a onesie usually. Okay, and those onesies have to meet parameters. Okay, safety parameters. Clothing should fit properly, be flame retardant, never too tight or too loose. Okay, no mix is hot. Clothing should include uniform, flight suit, outerwear, and undergarments. Okay, clothing should be layered for proper ventilation and heat regulation. Head and eye protection should fit snugly and meet or exceed occupational safety and health administration specifications. If you've ever been in an aircraft, they're loud. Okay, if you don't have proper hearing protection, you will have hearing damage. Okay, there's no you could, you will. Okay. Now, boots should be leather worn, protect feet against elements and fire. Gloves be flame retardant, protect hands against elements of fire. Uniforms have reflective materials and striping to increase nighttime visibility. Those nice little onesies, they're dictated of what they have to have. Okay. And the reason that they need, there are reasons why the wording is the way that it was. It shouldn't be so tight that you know, everybody can see everything. It shouldn't be so loose that it's hanging off of you. There's a reason. Now, when you get to the bedside, okay, and that's where critical care happens, at the bedside. They go in interfacility most of the time. You might not go straight to bedside, to be honest. You might stop at the nurse's station, figure out what's going on, get things broken down there, and then proceed into the room. Okay, you may go straight into the room. It just depends on what is needed at that point in time. With this, it's good. Let's just say this is considered good practice. Okay, it should be in something that they do, but let's just say it's good practice. Introduce yourself and the team members, okay? Permit the family to stay there, okay? And answer the questions, okay? Because, you know, you're taking that patient. If you're flying that patient out, they're not going to be able to go with. They're not going to be able to follow you, and they're going to have questions. Okay, usually sick as snot patient. The family might want to say goodbye. They might want to have a prayer. They might want to, you know, ask questions of you, and within reason, you should accommodate all those requests. Okay. Now, do you have to be part pastor for that prayer? No, don't do anything that you're not, you know, genuine with, or don't be disingenuous with that request. But if they would like to pray before you leave, respectfully stand there, whether you believe or not. Okay. When it comes down to QA, QI, flight services or critical care services have the same need. Are we doing what we're supposed to be doing the way we're supposed to be doing? So they have QA, QI processes as well. Now, the rest of this is just kind of like a history lesson as to ground and air transport. Okay. Now, I don't really think that that's all that essential, but I'll show you this. Okay. When we learn about trauma treatment, and mortality, morbidity, we learn from the military. Okay. They are in the trauma business. And what we've learned through years and years is if we stopped transporting horse and buggy and we could get somebody to definitive care in a reasonable amount of time, we reduced mortality rates. And through all of these iterations, these military conflicts, World War I, II, Korea, and Vietnam, if you think about the transport capabilities for each one of those, and how they improved each conflict, you see the reduction in mortality rates. Now, why is that in a critical care presentation? It's because, you know, carrying somebody from an aid station to a MASH unit behind the lines, well, what's the difference between carrying them from that versus Podunk Hospital to level 1 hospital? Okay, just a few more, I promise. Okay, and for the next couple, I'm not even going to show you the entire PowerPoint. Okay, it's just a critical care sort of review. A couple of things that I thought I would share with you. Okay, so when I talked about CAMES. This is CAMES, okay? Commission on Accreditation of Medical Transport Services. If you are a critical care organization, lots of them beat their chest or puff their chest because they have CAMES certification, okay? They set safety and professional conduct standards, okay? Medical transport team members talked about this just a few moments ago. Okay, system hospital mission needs may dictate configuration of that mission and that crew. Okay, if we're talking about flight, this is what you're likely to see. Okay, you've got a single pilot most of the time, not all. Okay, some places do have two pilots, but that is very few and far between, unless someone is in a training mode. Okay, you got a flight paramedic and a critical care nurse. Okay, if you've ever heard of or never heard of AMRAM, okay, Air Medical Resource Management. AMRAM is everybody's safety is everybody's concern. Basically, that's what you got to think. Okay, so this distributes the workload through all the crew members. All right, in mission planning, safety, decision making, ultimately, the PIC is in charge of the aircraft. Okay, PIC is pilot in charge. Okay, now everybody is supposed to have buy-in. Okay, 3 to go, 1 to say no. So if you've got a medic, a nurse, and the pilot, and one of them doesn't have a warm, fuzzy feeling about this mission, then that mission doesn't go. Okay? Your crew resource management, your AMRAM, that's what it is. Okay? Everybody has a vested interest in keeping themselves safe and others safe, and it's everybody's concern. When you're flight following, when you're looking out the plexiglass, and you see a Cessna, you need to have the ability to call out that danger because, you know, gravity is a thing. Okay. If you've never heard of this concept, a sterile cockpit, okay, when flight missions are critical, okay, the pilot wants everybody to shut up, to put it quite simply. Okay, in a sterile cockpit, the only time you're going to speak as in at all is if we are about to crash or something's about to crash into us. Okay, only vital essential communication during these phases of operation should be permissible. Okay, takeoff and landing. Okay, when he or she is going up or coming down, they want quiet, no conversation. We're not discussing patient condition, what we're having for lunch, or anything else. If it's not something that is critical to we're all going to die, then we don't talk. Okay. Refueling and taxiing air or ground, changing altitudes and headings. You know, that's when some problems may occur, but basically that sterile cockpit, it's for when things can go bad quickly. Okay, so if there's an emergency, an in-flight emergency, that would be a sterile cockpit. If you're taking off and have a chip light or any sort of problem, you might find that condition. Okay, so potential hazard reporting. Okay, there's a specific way for you to say, oh God, there's a plane. Okay, location, hazard, and heading. Okay, so you announce 10 o'clock, fixed wing, east to west, north to south, whatever the direction, as you can tell, that thing is moving. Okay, now everybody's going to start looking around. If you see it and you call it out, everybody's going to look in that general direction. They're going to, try to make sure that this is, a safe operation. Flight following. Flight following is basically if you are with some of the big aviation companies and there are big flight centers. When you have a mission, you go airborne, they're following you. Okay, your local dispatch center maybe as well. If you're around RDU, they may see you. But as far as flight following, making sure that you're okay, that's what flight following is. Every 15 minutes during a flight, they're going to check in and make sure that you are still airborne, still doing what you're supposed to do, no flight emergencies, etc. if you are on the ground. Every 45 minutes, they're going to check. Okay, and if they check in and you don't respond back, okay, 15 minutes following a missed check-in, they're going to activate their EAP, their emergency action plan. Now, with all of that, okay, going back to CAMES, CAMES has some requirements, just like National Registry has requirements, et cetera, et cetera. These are CAMES requirements. You're going to have to do live intubations. Okay, you're going to have to do that prior to beginning missions. Your flame retardant clothing, your onesie, must have 1-inch clearance from the body. So you can't have it so tight that it cuts off circulation, so loose that it's falling off of you. Safe operation of aircraft must always come before patient care. So ideally, you would do good patient care. CAMES doesn't care about that. Well, they do, but they don't. What they care about is your AMRAAM. That should come before anything else. I don't care if you're going to pick up a sick kid, or somebody that's a national treasure. Is it safe to operate? Are you doing safe flight operations? And then, when it comes down to it, while you're in the air, the pilot in charge, they are in charge of that flight. Now, most pilots, these are some of the criteria for them to fly that helicopter. Okay, 2,000 hours flight time, 1,200 hours in a helicopter, 1,000 hours as a pilot in charge, 100 hours as pick at night or during night flights. Now that is just to get on board, basically. Okay, that's how they can be the pilot in charge. Must be instrument rated for instrument flight rules. Airline transport pilot is recommended. It's not required. And then when it comes down to it, 5 hours total with 2 night flights prior to any solo missions. That's what CAMES says has to happen. And if you're a new pilot in the area, I would probably want you to have a few more hours locally, knowing what the alternative is. Okay, if you're going to be a fixed wing pilot, okay, 2,000 hours total flight time, 1,000 hours pick, 100 hours pick at night, must possess airline transport pilot certificate, and must be instrument rated. Okay, visual flight rules and instrument flight plans if you're going to do that sort of thing. Okay, to have flight, you got to worry about FAA regulations. Okay, and the ones that CAMES worries about more than anything else. 91, I think it's 35. Part 91, operator has regulations defined by the FAA. Small and non-commercial aircraft within the U.S. These regulations set conditions which the aircraft may operate, such as weather. Okay, so you can fly with your weather minimums. You cannot take off if you don't have your weather minimums. Okay, 135. Contrast 135 operator rules govern commercial aircraft such as non-scheduled charter and air taxi operations. So when it comes down to it, CAMES and critical care flight agencies are looking at these particular FAA regulations. Okay. Now, maximum 14-hour duty day for pilot in charge. And if they're going to exceed 14 hours, they will time out, okay? Which means they will be, if they're going to exceed while they're in the air, okay? The FAA gives them a little bit of cushion, okay, in an emergency situation. But if they're going to time out,
you could look at having a stranded flight crew at Podunk Hospital because that pilot timed out, okay? Which would cause another pilot to have to come and get them, or a ground unit to come and get them, and it's because if you exceed on what the FAA is happy with, the FAA will just take your pilot's license, right? Now, 8-hour minimum of bottle to throttle for pilots, minimum of 8 hours without ingesting any sort of alcohol before they show up, okay, to work. King's rudder wing standards, but here's the thing. Clear days, depending on where you are, can go not so clear really quick. So we're talking about weather minimum. You can fly, but you're accepting risks. So, all right. Sorry, one of my screens changed. It kind of knocked off my concentration. Okay. King's rotor wing standards below minimums. Weather conditions are under minimums. You can't fly. Okay. If you start getting below weather minimums, you are diverting to the nearest facility. Weather is the #1 cause of crashes when it comes to helicopters. And the #2 crashes is night flights. Now, I've lost 3 friends in a helicopter crash, and neither of those things were involved. A helicopter is an unstable platform, and if you have an in-flight issue, planes have a glide path. Helicopters don't have much of a glide path. Now, you've seen IFR and VFR. Okay, VFR, visual flight rules. A flight can take place if the weather is such that you can see where you're flying. Okay, VMC, visual meteorological conditions. So the weather hasn't interrupted your visualization of topography, etc. Okay, no intended instruments flying occurs under these rules. Okay, so nice, clear, sunny day. IFR, instrument flight rules. Weather conditions don't lend themselves to fly by clear sight alone, and this dictates that the pilot is to use instruments to fly. Okay. And if you got IMC, instrument meteorological conditions, the weather conditions allow for the use of VFR or VMC, the PIC could still fly under this. Okay. But sometimes the weather goes very bad very quickly, and then you can get into double IMC. That's what it's called. Okay, inadvertent instrument meteorological conditions. Say that real quick. Okay, what that means is you just flew into some soup, basically. Okay, you've lost in a real quick, fast, in a hurry kind of fashion. You've lost spatial awareness because you can't see anything. Okay. Now, this condition exists when the PIC began flying, the weather was good. Okay, and then they unexpectedly encounter weather that required instruments, and they're not rated for instruments or don't have said instruments. Oops. Okay. So here are some different parameters for, and again, these are all coming from CAMES. Okay. There are rotor wing standards, non-mountainous versus mountainous. Now, if you've ever heard of TAWs or NVGs, everybody knows what NVGs are, night vision goggles. TAWs you might not have heard of before, but you've probably heard it before, at least in movies. Okay, terrain, pull up. Terrain, pull up. That is terrain avoidance warning system. Okay, and aircraft have it on there. It's FAA regulated. And this industry is also CAMES regulated. Okay, there is a warning system that when you are approaching the ground, you're going to be getting those warnings. Okay. So anyway, helicopter LZs, in case you haven't had an LZ class recently, these are some of the LZ parameters. Generally 100 by 100. They've got to have somebody on the ground that they're talking to. Most likely, they want the same way in and out. Most likely, don't always have to, but they, if they were successful landing and they can go back the same way that they came, okay, they feel pretty good about that. Most of the time, you're going to see them circle high and once and do a little bit of a lower pass. And once that is done, they'll set down on scene. Talking to pilots that I know, vehicles crossing their headlights and that sort of thing, they don't really care. I mean, if you get them a good a good LZ, it'd be great if you had some cones out. I mean, if you could put some flashlights inside those traffic cones, not only to help weight them down, but to help illuminate them. Those pilots, the majority of them are ex-military, and they can do wonderful things in those aircraft. Okay, so spotting where the issues are. Okay, anything that they can't see from the air. Okay. Power lines, guy wires, things that we can see from the ground. If you're going to land them somewhere on the 911 side, walk that field and make sure you know what the conditions are. You have to worry about brownout and FOD, okay, foreign object debris. Fresh cut hay or grass or things like that, that prop wash is coming down 100 miles an hour, and all of that grass and stuff that is freshly mowed or what have you, debris, all that stuff is going to get blown up in the air, and not only can it become, things for you to avoid on the ground, but it can also get sucked up into the props, which is a bad thing for everybody. Okay. Now, let's see. They do love helipads because they're permanent, they're fixed, and nobody's going to be throwing up anything in their pre-planned approach that is going to mess with them. Okay. Whereas if you didn't see the wires that were leading into that field that you're about to land them in, yeah, they can get surprised by that. They can take a look at the windsock and see where that is, and know what the wind on the deck is doing. If they have an in-flight emergency, it depends on what's going on. Okay, some things are a hard stop. Okay, if you got a fire or engine failure, you have to land immediately. And hopefully that's going to be a controlled landing, and sometimes it's not. Okay. They all use Jet A fuel, and it is highly combustible. Now, if you got an engine fire, engine failure, it doesn't have much of a glide path, and we'll hear them talk about auto rotation and hard landing. Hard landings, that is difficult to walk away from, but people do. If you got a chip light or you have a transmission low pressure, that's land ASAP, okay, as soon as possible, and that's going to be more of a controlled landing. And sometimes those chip lights, those warning lights, that's going to be when you put stress on the airframe, when you're starting to lift up, when you just fire the engine, when you're about to lift. That's when you might get a chip, but you can get it at any point during flight operations. And then if you're going if you just hear something that's non-critical, non-flight critical, that's when you're going to land in the closest convenient place. Okay, most likely a known LZ, or one that you have done a high-low on so that you know that it's safe. You don't have any ground guide, but you've inspected. The problem with that is nighttime operations, NVGs, they're great, but they can only show you so much. Okay. A couple of things that they have to worry about. And again, CAMES beats all of these things into their heads. When it comes to in-flight emergencies, you got time, a little bit, not much, and I mean not much. You're to do the following: lay the patient flat, turn off the oxygen source running, assume a crash position, and that is seat belt secured, sitting up straight. Those seats are going to have some shock absorption, but not a heck of a lot. Okay. Tighten your helmet, lower your visor, knees together, feet flat on the floor, 6 inches apart. Do not put them up underneath the seat, because if you do, you're going to become an amputee. Cross your arms over your chest, chin to chest position. Okay. Now, here's the thing, folks. Depending on the altitude, you have seconds to do that. That's what flying in a helicopter is like. Post-crash sequence, assuming all, or at least you, have survived. Okay. Turn off in order the throttle, fuel, battery, rotor, brake, and your oxygen. Okay. Hard landing, grab the survival kit, exit the aircraft, and go to the 12 o'clock position, which is in front of the nose of the aircraft, assisting survivors. And then your priorities are shelter, fire, water, food, and signal. Okay. So remember, when a truck breaks down, call another truck, you're on the side of the road, kind of a pain in the butt. When an aircraft has an issue, these are the things that they have to worry about. You have an ELT, okay, emergency locator, okay, your emergency locate transmitter. That ELT, you know, that sends out a signal for those people that are looking for you. You know, if you want to think of it as something, think of it as the black box, okay? But it may or may not be activated, okay? You can manually activate it. It can also be tripped by 4 times normal G-force, okay? If you have a hard landing, the ELT could go off, okay? A really hard landing, it's going to go off. A crash, yeah. When rescuers approach a crash site from the air, the constant repeating audible alarm over the headset you're going to hear, okay, when you're getting that, that is going to be the ELT that's activated, and it sends out a signal, okay? When you get close, you're going to hear that signal. Now, that's enough about that one, okay? So, some other things that I'm going to throw your way in just another quick presentation, and that one is completely up to you whether you watch it or not. It's going to be a couple of things about gas laws, a little bit of flight physiology stuff, just in case you ever did want to fly. Some other things for you to be concerned with. And yeah, so I'm going to end this one for now, and I'll be putting up another one in just a few minutes, but it's going to be really short and just about flight physiology and stuff. All right. Hopefully I didn't bore you guys to tears, and anyway, have a good week.